Well, hello. It's my pleasure to be with you for this session on diet and exercise and heart failure. I'm grateful to the organizers at the Ted Rogers Center for Heart Failure for this opportunity to share this as a webinar with you. My name is Paul O. I'm the Director and Good Life Fitness Chair in the Cardiovascular Disease Prevention and Rehab Program at the Peter Munk Cardiac Center, Toronto Rehab, and University of Toronto. Here are my disclosures that in the past year, I have served on some advisory boards for Biogen and Novartis, and I hold some research funding from Good Life Fitness for a research chair, as well as research activities with Apple. Here's the setting that I'm coming to you from. I work in a cardiovascular rehab program where we'll see, actually that should be 2,000 patients per year at two sites, Toronto Western and Toronto Rehab. Pre-pandemic, we worked with people for up to 6 months. Now we're in hybrid models for about 4 months for each individual with weekly visits, either in person or online. And we also do a fair bit of stress testing. And all of this applies to the heart failure population, as well as to those living with coronary artery disease and other cardiovascular conditions. So the ideas for today about focusing on diet and exercise are very much in the wheelhouse of our rehab programs. And I thought today we would touch upon a few different things. One around dietary ideas, that here's the 4 messages up front, that we'll touch on sodium, fluid, protein, and dietary pattern. Around exercise, we'll do a little bit of a backgrounder about understanding exercise limitations, describing why rehab and exercise might be a good idea. If we're going to move into providing advice, then we can think about movement, first of all, aerobic and resistance exercise prescriptions, and then some data about personalization and why that might be important in the heart failure setting particularly. And throughout this, I'll share some resources, some relatively new studies, and some patient education models that can be used with your patients in your practices. So this is hosted by Ted Rogers Center, and I'm delighted to be able to kind of point to some excellent patient education resources. They're very relevant to these topics of diet and exercise. And if we turn to the platform that then speaks out to the nutrition guide for heart failure, there are some motherhood things that are there that we all kind of convey to our patients on a regular basis, the core topics around fluid and sodium restriction. So if we start there and then dive a little bit into data and the rationale behind some of these advice, then that might be a useful place for us to start. And I want to go back a few years and celebrate one of the Toronto contributions to heart failure. It's interesting, at some point, even just recently, that we've had to kind of provide data about the perils of sodium, even though we've all probably thought about restricting sodium for many, many, many years. There actually wasn't a lot of kind of solid information about this. Joanne Arcand, who's from the University of Toronto and works at hospitals on University Avenue, conducted this study with a number of heart failure colleagues to look at a group of ambulatory individuals with heart failure and examined intake of sodium at baseline and see how this predicted future trajectories over 3 years. And you can see if you segregated out the population by tertiles of sodium intake, those kind of lowish, the kind of guideline group that's in red, versus those with medium levels of sodium intake that might actually represent the average Canadian, versus those who have higher levels of sodium intake, like greater than 2.8 grams. You can see if you look at sodium intake and acute decompensations of heart failure requiring hospitalization, or indeed looking at mortality, there actually is a striking gradient that the more sodium intake that you have, the higher the possibility of decompensation or actually dying. So sodium intake, it certainly does matter. And the guidance that we give these days around restricting to 2 grams or less actually makes sense in terms of evidence. So back to the Ted Rogers kind of patient education site, then in these friendly infographics, the sodium guideline of 2,000 milligrams per day is kind of shown in clear guidance. And the other things that are pointed out for both our patients and us is to remind us that Although we may be tempted to focus in on things like salt shakers or food selections at the grocery store, remind us that the vast majority of sodium in the typical Canadian diet comes from processed foods, either things that are canned or pre-prepared or takeaway or dine-in restaurants. So if one really wants to have an impact on sodium intake, then this is the segment that we really need to focus on. And one of the kind of health literacy things that we can help our patients with is to learn how to read a nutrition label, because that's where the control is. If you want to do something fun and something kind of eye-opening for you and your patients, it's often useful to see, well, just what are you doing in terms of your own sodium intake? And there are some nice calculators online. This is one from Project Big Life that our colleagues at the University of Ottawa have developed. And you can see that if you go through the online questionnaire and answer items, particularly in these domains, that you'll assess what your daily sodium intake might look like. And you can see that these questions really dive into how much of those processed prepared foods are included in your regular diet. Fun aside, when I looked at my last week's sodium intake, it actually came out to about 2,500 milligrams. A good wake up to say, maybe I can actually change my own intake around this way. And certainly if I was living with heart failure, this is something that I'd want to pay some attention to. So a good thing to build into your practice is just have people assess their own and understand their own dietary patterns. Number two in the dietary cascade is understand your fluid intakes. And we will certainly implore on a regular basis, don't drink too much, go with the recommendation provided by your physician, cardiologist, nurse practitioner, heart failure specialty program. And often we'll say the 1.5 to 2 liters and make sure we include everything. A fun activity, of course, is to actually do this measurement. So if you invite your patients to actually get a 1.5 liter bottle, it could be an empty soda bottle, for instance, and through the course of the day, every time they drink something, they could put the equivalent amount of water into that bottle and see how it fills up. So it's a great way of learning and a visual cue to whether you're getting too much or too little fluid through the course of your day, as a way of good self-management. Number three, beyond sodium and fluid, is to remember that people with heart failure, even though they might be overweight, might have insufficient caloric and nutrient intake. And this is important, as shown in this recent study published in JACC Heart Failure, that says that people who have insufficient caloric intake, shown in blue, or compared to those with adequate caloric intake, as well as adequate protein intake, there is quite a difference in terms of outcomes. And in this case, when one looks at heart failure related quality of life, those people who have poor nutritional status tend to have worse quality of life, but also very importantly, those with poor nutritional status have a much higher risk of coming back to hospital. So about 1 in 2 people will actually come back to hospital and spend an inordinate amount of time in hospital. So often we focus a lot on getting medications titrated to the right levels, but we sometimes ignore the nutritional status. And this can be very important in terms of people's trajectory in the near term as well as longer term. So item number 4 is thinking about patterns. How do we wrap this up? Because people don't just eat sodium. They just don't drink water. They don't eat protein on its own, but it's part of a pattern. And we can reflect on the healthy patterns of eating that we recognize as important in cardiovascular disease management. And a couple of them that we'll call out: the Mediterranean pattern of eating, or Canada's Food Guide, the most recent version, both point to an emphasis on vegetables and fruit, because that's what's going to give us the essential nutrients, not too much sodium in our diets. Think about the proteins that are helpful: fish and seafood and poultry and eggs. And so nothing is really disallowed, but we should have it in the right kinds of quantities. And then both of these programs are going to call for less processed anything, which is going to give us lots of sodium and is probably less healthy for us. Is there evidence that the patterns can make a difference? Well, here's a couple of pieces that we can point to. This is a longitudinal Swedish study of over 30,000 individuals who were followed. And in this population, the instant heart failure cases were looked at over time. And one can see that if one looks at Mediterranean diet scores. So the greater adherence to Mediterranean pattern of eating was denoted by these quartiles. Quartile 4 is the most adherent, quartile 1 is the lowest. And there is actually this striking relationship that the more Mediterranean one is, the risk of heart failure goes down. And this is true for MI, it's true for heart failure, it's true for stroke. So being Mediterranean is clearly a good thing vis-a-vis cardiovascular risk. And this study that looked at a randomized trial of Mediterranean diet, the PREDIMED study that I'm sure we're all familiar with, called out specifically that in a subpopulation that followed the randomization, that following a Mediterranean pattern of eating that was supplemented with extra virgin olive oil or a handful of nuts every day, those simple measures led to less markers of cardiac injury like proBNP over time, and this was significantly different. So eating Mediterranean actually makes a real difference. Another patient resource that you can turn to can be found at cardiaccollege.ca. Here we have lots of details about eating healthy, including a Mediterranean pattern evaluation. So want to be more Mediterranean, evaluate yourself and add one more thing per week in terms of getting towards that pattern that can be healthier. Okay, second domain is around exercise. And this lovely review in JACC that was published just a couple of years ago describes in great detail exercise intolerance in heart failure. This infographic from the paper points out that there are many things that contribute to people feeling tired and unable to carry out the things that they need to do. And it may relate to pulmonary reserve, cardiac reserve, but also not to forget the contribution of muscle dysfunction as part of the story as well. And then there are other things around vascular dysfunction, obesity, nutrition is called out here as well. So exercise intolerance is common in lots of people. There are many deficits, and it's important to figure out where the specific issues might lie so that we might think about the potential interventions. The article calls out the many pharmacologic things that we can offer up to people, and we're very good at that, and it's gotten more complex. Not only does it help heart failure, but it also helps exercise outcomes. And of course, exercise training is specifically called out as something that we can offer up to individuals. In a recent Cochrane review, where exercise interventions are looked at in the context of cardiac rehab, for people living with heart failure, there is evidence that good things happen when you exercise regularly. Statistically significant reductions in hospital admissions, but also important trends around all-cause mortality and health-related quality of life can be achieved with exercise interventions. So hence, the patient education materials at Ted Rogers will call people to action in terms of getting exercising and being less sedentary and moving. A couple of bits from personalization that I just want to call out in the last couple of minutes here. This is the standard exercise model that we offer up to most people with heart disease. Safe, effective, tried and true for decades. That we get people to increase their intensity, maintain that over time, cool down. This is safe and effective and leads to improvements in fitness and functionality. The personalization that comes in that's a little bit more recent in literature and applies to heart failure allows us to vary up and down the exercise intensities. So-called higher intensity interval training, for you at the gym, it might actually be called HIIT. We don't take people that high. In this model, for instance, people might only achieve a peak heart rate of like 118, but the idea is you go higher, then lower, higher, lower. And if you do that, you can actually achieve greater gains in fitness in shorter period of time with some more enjoyment. This is actually very topical in the literature and has been looked at in meta-analyses, and they confirm that we can actually improve peak VO2, but there is some variation in literature depending on how well people can actually adhere to that HIIT protocol. The final thought here is that at the other end, so not doing HIIT, but doing things for frail individuals was actually just published recently in the New England, where a group of cardiovascular researchers with exercise researchers and geriatricians came together and looked at this study in 359 older individuals with heart failure, all of whom had frailty or pre-frailty. So if we can customize an intervention that looks not only at aerobic and resistance, but also balance and mobility, and do this in a very stepwise fashion, so that people in this colorful graph people are doing more over time, doing more colorful things over time in terms of their exercise program, we can actually improve physical performance on a battery as well as 6-minute walk tests. There weren't clinical outcomes demonstrated in this particular study, but hopefully those things will follow in future investigations. So if you want more exercise resources, go to Cardiac College. There's great stuff about getting active, including a whole resistance training library that people can do. This is designed for people living with heart disease. And if you want some specialty support on how to do this, get them into cardiac rehab, as the Ted Rogers Center would implore. So get referred. There's referral forms located at the website for both the rehab center as well as for the Toronto Western Center. So here's what we've discussed: some good dietary ideas, sodium, fluid, protein, and patterns, some exercise ideas, and how to help people get more functional. Lots of resources available. Thanks for your time. I'll look forward to seeing you in the question period.